And so, hi, everybody. Welcome to today's session of the T-CAIREM trainee rounds. We're really excited to have all our attendees here today and two great speakers. Before we get started, I just wanted to give a brief introduction to T-CAIREM. So the Timur Center for AI Research and Education in Medicine at the University of Toronto has been made possible by the generous donation of the Timur family. T-CAIREM is an interdepartmental center that serves as a focal point for collaboration among healthcare professionals, trainees, researchers, computer scientists, engineers, and industry. Our goal is to transform health through AI. I also did just want to note to our attendees that by attending this event, you're consenting to be photographed or recorded for non-commercial use by T-CAIREM, and also that our chat function has been made accessible to all our attendees. And we please ask that you submit any questions that you have throughout the presentations into the chat box, and we will address those during the discussion portion following the presentation. So with that, I'd like to begin by introducing our first presenter. Our first presenter is Lianghong Chen, a master's student in computer science at Western University, specializing in deep learning and reinforcement learning. The project that he's going to present to us today is titled Conditional Probabilistic Diffusion Model-Driven Synthetic Radiogenomic Applications in Breast Cancer. So whenever you are ready, Liang.
Okay, can you see my screen? Okay, thanks for introducing me. So I'm gonna start. And today I'm gonna share, sorry. Okay, so today I'm gonna share a study about synthetic radiogenomic application of breast cancer driven by conditional probabilistic diffusion model. First, I wanna quickly introduce the breast cancer. Breast cancer currently is still a significant health challenge for women. And a survey in 2023 in United States declared that about 350,000 women would be diagnosed with breast cancer, and about 40,000 patients were anticipated to die from it. The treatment of breast cancer is complex due to its heterogeneity. The heterogeneity of the breast cancer refers to the diversity observed in breast cancer tumors at the genetic, molecular, and clinical level. On the molecular level, if we only consider two biomarkers, ER and HER2, we can categorize breast cancer as four subtypes based on their expressions, like ER positive, HER2 positive breast cancer, ER negative, HER2 positive breast cancer, and so on. In our study, we are most interested in HER2 positive, ER positive breast cancer. There are a few reasons that we are most interested in the ER positive, HER2 positive breast cancer. Some studies have shown that ER positive, HER2 positive case have a better survival in first 5 years, but have a higher recurrence risk after 5 years compared to ER negative, HER2 positive case. Besides, our previous work indicate that ER positive, HER2 positive breast cancer is also heterogeneous, which means this type of breast cancer can be further categorized as two subgroups according to the different survival outcomes of patients. As shown in the survival plot, the patient in subgroup 1 overall have a good survival probability, while the survival probability of the patient in subgroup 2 is significantly reduced after 2,000 days. There is a lack of research on ER positive, HER2 positive breast cancer, but it is important to determine these subtypes and make personalized treatment plan for patients, because different subtypes will lead to different response to the treatment. However, the problem is how to determine these breast cancer subtypes. The common strategy used to determine the breast cancer subtypes is performing a biopsy on the patients. Biopsy is invasive examination. The operators will take a small piece of tissues from patient's breast cancer and test samples to assess the biomarkers in the breast cancer cell. However, this method has some limitations. Since the operator only takes a small piece of tissues, it cannot make sure the taken tissue is representative for the entire tumor. Besides, some biopsy procedure may be expensive and patients may also have a risk of infection and feeling uncomfortable after the biopsy. So, are there any methods that can non-invasively diagnose the tumor comprehensively? The answer is yes. Radiogenomics is a potential promising alternative. Radiogenomics is an emerging field that combines emerging techniques, genomic data to predict tumor characteristics using the artificial intelligence technique. Specifically, by studying correlation between medical image and genomic data, they can be converted into each other through proper method. The radiogenomic-based method have a lot of benefits. In radiogenomic study, we are possible to predict tumor characteristics from MRI scans. This may be potentially reduce the cost and the needs of invasive procedure. Besides, the radiogenomic also allows to detect breast cancer early and provide more comprehensive analysis for tumors. However, current radiogenomic study is actually facing a challenge, which is data unpaired issue. Data unpaired issue refer to the missing of image data or genomic data in the data set. In our study, we collect data from two databases. We collect MRIs from the Cancer Image Archive and collect genomic data from the Cancer Genomic Atlas. We call these two databases TCRA, and TCGA later. TCRA provides a large public accessible collections of medical image paired with the clinical and genomic data for cancer research, while TCGA catalogs genetic mutation for cancer using the bioinformatics. From the TCRA, we found 138 patients and only 91 patients with MRIs. For the TCGA, we found 1,097 patients and only 754 patients with complete genomic data. There are only 61 patients in common between two groups, which means only these 61 patients have both MRIs and the genomic data. The remaining 693 patients from TCGA don't have MRIs. Therefore, the data unpaired issue happened. To solve the data unpaired issue, the common strategies are collecting the missing data or performing data augmentation. Collecting more data is not feasible in a lot of scenarios because it generally will cost plenty of time and money. Instead, generative AI-based data augmentation method like diffusion model is more doable. Diffusion model is a state-of-art model in generative AI. It can learn patterns from known data and generate new samples like images and text from new promotes based on the learned pattern. This generation process is used to augment the missing data and solve the data unpaired issue. We know the power of the diffusion model. Then we expect to use it to solve the data unpaired issue in our breast cancer radiogenomic study by artificially synthesized MRIs. After we have the synthesized MRIs, we use them to predict the tumor characteristics. Therefore, accordingly, we have two aims in our research. We first aim to build a conditional probabilistic diffusion model to synthesize MRIs, and then build some classification and survival models to predict tumor characteristics and other clinical information. Then our study is designed as two parts. according to our aims. We first use MRI and multi-omic data of 61 common patients in TCGA and T-CAIREM to train our diffusion model. We use the well-trained diffusion model to synthesize the MRIs for 693 patients in TCGA without MRIs. Then all 754 patients from TCGA will have MRIs. To predict clinical information from MRI, we extract features from MRIs using some existing tool. One thing need to be noticed is there are only 66 patients out of 754 patients have matched subgroup data, and only 740 patients out of 754 patients have matched survival data. We use this matched data to train classification models and survival models to predict subgroups and survival information respectively. Now we prepare the data for model training. We first pre-process the genomic data. Our genomic data involves gene expressions, copy number variation scores, and the DNA methylation. For each type of data, each row represents the information for one patient. We concatenate 3 types of data and get a 3D tensor. In this tensor, each layer includes 3 types of genomic data the patient have. Then we use the Bayes tensor fractionation method to decompose the 3D tensor and get a 2D tensor. Each row of the 2D tensor represents decomposed multi-omic data for a patient. This decomposed multi-omic data later would be used as promote for diffusion model. We process our genomic data in this way because genomic data is sparse and noised. Using a Bayes tensor fractionation method to decompose the tensor can improve the accuracy and computational efficiency of the model. Then we pre-process the MRI of 61 patients from TCIA. The MRIs of this patient involve 3 different types of views. Some patients have side view, some have top-down view, and some have front view. In this study, we choose the side view because this was easy for human to perform visual inspection to check the quality of the generated images. In addition, to improve the efficiency of the model training, we further orthogonally project the 3D MRIs to 2D. So far, we have prepared the MRIs and the multi-omic data. We then use this data to train our diffusion model. The training of the diffusion model involves 2 common steps, which are forward diffusion and backward diffusion. In the forward diffusion process, the model will gradually add Gaussian noise to the MRI using a predefined noise scheduler. During this process, the image will get more and more noise and finally become a pure noise image. This step will let the model know the relationship between noise image and the number of steps we add noise. The backward process is the inversion of the forward diffusion process. Based on the noise adding process learned from the forward diffusion, the backward diffusion step uses a U-net model to denoise the pure noise image to gradually construct the MRI according to the patient's multi-omic data. As we mentioned in previous session, each row of the decomposed data is the multi-omic data for each patient. We take the multi-omic data of each patient and use a linear method to extend it to have the same shape with image so it can perform inner product with image. This will allow the model generate image according to the multi-omic data. To better align multi-omic data with MRIs, we add a coarse attention layer at the middle of the U-net. To test the luminance of the model, we use the gene expressions to repeat our experiments. Then I want to show the performance of our diffusion model and how it compared to other state-of-art baselines. To comprehensively evaluate the performance of our model, we include 3 performance metrics. They are fractured inception distance, mean square errors, and the structure similarity index measure. We call them FID, MSE, and SSIM respectively. FID is used to measure the similarity between synthesized images and the real images. The minimum FID is 0, which indicates the images are exactly same. The maximum FID is positive infinity, which indicates the images are completely different. In this task, we expect to have a low FID. MSE is another metric that's commonly used used in the image synthesis tasks. MSE assesses the accuracy of the generated images. A low MSE implies a small error at a higher accuracy. SSIM measures the quality and the structure similarity for the images. The range of SSIM is from 0 to 1. A high SSIM indicates high image quality and structure similarity. These 3 metrics evaluate the model's performance through different aspects. We compare both multi-omic version and the gene expression version of our model with other 3 generative models, which are autoencoder, transformer, and GAN. From the result, we can find the performance of our model comprehensively surpass all the baseline models. Then we perform some visual inspection for the generated images. Here for the patient in the test set, we list the real image synthesized from multi-omic data, and the image synthesized from gene expressions. By comparing the similarity between real images and synthesized images, we can find most of images have similar shaded and highlighted region. We then perform visual inspection for patient in the unpaired set. Patients in the unpaired set do not have real images, but we compare the similarity between images synthesized from multi-omic data and the images synthesized from gene expressions. We synthesize images for all 693 patients without MRIs, and the percent synthesized image of random and the percent synthesized image of random select for patient here. We found 2 synthesized images of each patient have a similar breast shape, structure, shadow, and highlights. To predict ER positive, HER2 positive subgroups, we use the MRI features and the known subgroup data to train classification model. The MRIs are synthesized from multi-omic data and the gene expressions respectively. We try 4 different methods to extract image features, including Radiogenomic tool, VGG16, ResNet15, and Inception version 3. Radiogenomic is a tool specifically used to extract radiogenomic features from medical image. VGG16, ResNet15, and the Inception version 3 are convolutional neural networks with different structure and trained on different image dataset. To evaluate the performance of this classification model, we select AURC, AUPRC, and F1 as our performance metrics. AURC can evaluate the ability of the classifier to distinguish different classes. AUPRC and F1 evaluates the model's ability of identifying positive instance from different perspectives. Compare the result of each group, we can find although the experiment methods are different, we all achieve good performance. We also use the synthesized image to perform survival analysis, similar to the ER positive and HER2 positive subtype prediction. We try 4 methods to extract features of image synthesized from multi-omic data and gene expression data, and then chain 2 survival models, which are deep survival model and cost feature model, to predict survival outcomes of patients. The model performance are evaluated by calculating concordance index. The concordance index is a statistic measure used to evaluate the predictive accuracy of the survival model by assessing the agreement between predict and observed outcomes. A high concordance index score implies high accuracy. The range of concordance index is from 0.5 to 1. Compare the result between different experiments. We found both a multi-omic version and the gene expression version can get the best performance when training Cox feature model using the ResNet 15 to extract features from synthesized MRIs. Our study is expect to have some impact on research field and the community. The diffusion model we proposed for MRI augmentation provide a new perspective for radiogenomic study, which may advance the medical imaging and computational biology. Besides, the success of this study may provide a non-invasive examination option for the patient to access their clinical data. Patient may just need to get an MRI scan in the hospital and then pass it to our model to analyze. Then they can get a comprehensive report for their conditions. The doctor can base on the report to make a personalized treatment plan for the patient. Furthermore, since we have synthesized MRIs for patients in TCGA, these MRIs can be further used for relevant breast cancer study. Compared to using real data from patients, using synthetic data can better protect patients' privacy. Moreover, using MRI to detect and diagnose breast cancer is easy to be deployed in real clinical settings, especially in underserved communities. This can enhance the accessibility of the breast cancer screening. For the next step, we may plan to train models that can analyze different views of MRI to satisfy the diverse need in clinic. We may also want to include more prediction from MRI. They may include more subtypes, gene mutations, and so on. This may help doctors gain a deeper understanding of patients' conditions. In other cancer-related studies, if there are some similar challenges, we hope this approach could adapt to solve the problem. The smooth progress of this study cannot be achieved without the support of funding from Canada Research Chair Tier 2 program, Canadian Institution of Health Research, Nature Science and Engineering Research Council of Canada, and the Vector Scholarship in Artificial Intelligence. I also appreciate the contribution from the co-authors in the project. Among them, Dr. Pinzhao Hu is my supervisor. He is the Canada Research Chair in Computational Approach to Health Research and the Associate Professor in Biochemistry Department at Western University. You can contact us through the email and find more about us in our website. That's all for my presentation. Thanks so much for your listening. I'm happy to take any of your questions.
Thank you so much, Lianghong. I'll provide an opportunity for anybody in the audience to put their questions in the chat, and we'll just briefly maybe answer one question given our time limitations. See if we have any questions. Okay, if we don't have any in the chat at the moment, I welcome anybody to post their questions later. I just have one quick question, if you could answer briefly for us. So you mentioned there was a really interesting comparison with your model compared to the other generative models, and really impressive to see that you surpassed these baseline models. Just wondering if you have any sort of general comments on the advantages that your model has compared to other models that have previously been used to generate similar images that you think has allowed it to surpass these types of models?
It's a very interesting question. So basically, our baseline models like autoencoder, transformer, and GAN, it generates image like it's like one step. So, but the diffusion model is different. It will generate image step by step. So at each step, it will consider if it matched our if it can well align with our multi-omic data. In this case, the alignment of the image and the multi-omic data will be improved. And also, since this kind of step-by-step generation also will improve the quality of the image. So to conclude it, that's the true reason the diffusion model can perform better than other baselines.
Wonderful. Thank you so much. And thank you again for your great presentation. I think in the interest of time, we'll move on to our second presenter for today. So maybe as he gets set up and his slides are brought up, I can begin with our introduction. So our second presenter today is Dr. Timur Latypov, who is currently pursuing a PhD at the University of Toronto's Institute of Medical Science. His presentation today is titled Signatures of Chronic Facial Pain, Interfacing Artificial Intelligence and Multimodal Brain Imaging. So welcome, Dr. Latypov.
Thank you very much for introducing me. Can you hear me and can you see my slides? Okay. Excuse me. There is, I think, something in the microphone. Okay. I'll start my talk. Thank you very much for joining today. My name is Timur Latypov. I'm finishing my PhD at the University of Toronto under the supervision of Dr. Mojgan Padai. And I want to thank T-CAIREM for the opportunity to present here. We see many fantastic presentations from different great researchers, and the quality and diversity of this work is fantastic that we see in here. So my current project is more of the classical machine learning as a research tool, and more about that in the next 20 minutes. All right. So I'll start from showing you two pictures of the brains. Both brains in here, in fact, appear fairly similar in normal, but one of these scans, in fact, belongs to the patient that is experiencing the excruciating chronic facial pain. This pretty much highlights the challenge clinicians and researchers face in identifying pain, since there are no reliable objective measures of this condition. The severe pain I mentioned earlier essentially is called trigeminal neuralgia. Just a bit of a disclosure, pardon. I used ChatGPT for image visualization in here. So I asked the model to illustrate trigeminal neuralgia based on how patients typically describe their pain. And these disturbing images pretty much capture many aspects of trigeminal neuralgia, which is known as one of the most intense and debilitating pain syndromes human can experience. It typically affects about 5 in 100,000 people annually, and the impact of this condition on quality of life is very profound, with many patients experiencing challenges in performing even daily activities, such as brushing teeth or eating. So typically, trigeminal neuralgia includes features like episodes of electric unilateral facial pain, and the complexity and severity of this disorder makes it challenging to treat, often requiring surgical interventions when medications fail. Surgery, however, in many cases, have the capacity to offer significant pain relief. So it's important to mention that in addition to the trigeminal neuralgia, there are other pain syndromes that are affecting the trigeminal nerve. And these conditions demand a nuanced approach for diagnosis and treatment. Currently, there is a classification system being used for that purposes. It's called International Classification of Headache Disorders, or ICHD-3. And that system provides specific criteria on each condition, which are primarily focusing on clinical features of pain, neuroimaging, findings, and medical history. Probably it looks very complicated in here, and yes, it is, because there is always degree of uncertainty and inconsistency with regards to many of those measures. And this essentially leaves clinicians with a difficult challenge because they have to just compare one pain to the other. And as you can see across the board, they appear fairly similar. And clinical characteristics for these facial pain syndromes are not fully stratified based on the type of pain. And we need a further research to fully understand the interplay between these characteristics, type of pain, and its substrate. So these are only few challenges we already had a chance to identify within first couple of minutes of my presentations, and there are obviously more of those. Specific challenges related to the treatment of trigeminal neuralgia because TN necessitates personalized predictive approaches for determining surgical candidates. But the common situation is that we usually offer the surgical procedure, but we cannot really tell what are the chances of the patients to be pain-free. And that sometimes might lead to trial and error approach for treatment, which can be both inefficient and distressing for patients. And we think that technology in that sense has a capacity to offer us the means to solve some of those challenges. So in a very general view, my current work uses artificial intelligence and brain imaging to investigate trigeminal pain and identify individual level imaging and clinical signatures of it. For specific purposes, essentially, we focus on 3 principal directions, which I will walk you through today. The first direction and the first study in here was to try to distinguish trigeminal pain and healthy controls using imaging only as a sole modality. So the idea is that can we really tell if these similarly appearing brains are actually different? So second direction was to identify prognosticators of successful surgical treatment. And finally, we wanted to look at the trigeminal pain signatures in more clinically diverse population of people with a condition called multiple sclerosis. And we think these 3 directions of investigation essentially provide us with complete insights on trigeminal pain and its objective signatures. So how we do that? For the sake of time, I'll probably skip most of the technical details. I'll primarily focus on the aspects related to the data in here because data is important when we do the machine learning research. And this work would not be possible without the rich data set that has been collected in Toronto Western Hospital for decades. So as a part of my work, me and the research team, we screened almost 1,000 subjects with facial pain and directly investigated 445 of them as a part of 3 of our studies. So we used the neuroimaging data from these subjects and clinical data. Just briefly about what we did in neuroimaging, we took some of the imaging data sets. One includes the T1 weighted imaging and processed them using specific software called FreeSurfer. So we can extract the thickness, surface area, and volume of certain gray matter structures in the brain, and then feed it to the machine learning algorithm. In one of the studies, we also looked at the white matter imaging, diffusion tensor imaging, that is essentially in a simple way with a wiring of the brain. And we analyzed this using the software called DTI, it's from FSL. So one of our first works in this direction that we in fact published last year was focused on neuroimaging and AI as a sole means to distinguish trigeminal pain from healthy controls. So to do that, we collected the data, which consists of 1, classical TN subjects, which represents the episodic electric shock-like pain. Second group was trigeminal neuropathic pain, which is essentially the umbrella group who is experiencing the constant facial pain nonstop, and then healthy controls. So we analyzed them using a combination of unsupervised and supervised learning methods. Just a little bit about that. So unsupervised learning analysis consisted of T-distributed stochastic neighbor embedding, or TSNE, or principal component analysis, in a sense, nonlinear and linear dimensionality reduction approaches. And in both cases, in fact, we could see that healthy controls are being separated from trigeminal pain subjects, which you can see in these double clusters. Interestingly, however, we also can see that one type of pain was inseparable from the other. And spoiler alert, we will see that later on as well. So we moved on to run the supervised machine learning task, where we compared first classical TN and healthy control using machine learning. And this, in fact, achieved a very high accuracy. Model was able to tell apart between healthy and pain-experiencing brains with a high accuracy, up to 95%. We tested two models, logistic regression and random forest, and both performed very well. So this results essentially confirm that the neuroimaging, in fact, can be used to identify chronic pain, even if these brains look fairly similar on a macro level. Similarly to that, we also ran comparison of constant pain against healthy controls, which also achieved a very high accuracy in distinguishing one from another. However, when we compared one pain to the other, classification essentially failed, and model couldn't tell apart constant and episodic pain, which was very interesting for us. So this figure illustrates some of the top predictors for each comparison. This includes, for example, regions of the brain like insula, temporal cortex, olfactory regions, thalamus, and fornix. And several interesting observations can be drawn from here. First is that if you take a look at the first two rows, predictors of trigeminal neuralgia and trigeminal neuropathic pain, in fact, appear very similar. And this is further supported by the second point, because only two structures were significantly different between classical TN and trigeminal neuropathic pain when we looked into post hoc statistics of important predictors. It was insula and orbitofrontal cortex. So these findings essentially suggested the feasibility of using neuroimaging alone to distinguish pain from healthy controls, but it also begged the question about constant and episodic pain syndromes, proving that just these clinical measures might not be sufficient to draw this line between different types of pain. This essentially opened the bigger question regarding the pain clinical expression and what does that actually mean. And this is something we investigated in our second work, focusing on variation of symptoms within trigeminal neuralgia. So we know that, for example, some patients may report that they are experiencing pain only in the certain year seasons. Others say that pain is constant, but there are no specific information about the clinical implications of these patterns and what does that mean in the context of future surgical outcomes. So in this more recent study, we decided to consider trigeminal neuralgia as a one disease containing several disease categories inside it. Each category essentially can be distinguished by brain imaging signatures, clinical characteristics, but ultimately the surgical outcomes. So we proposed the ML-driven approach to stratify these disease categories of trigeminal neuralgia. For that, we included 102 subjects who was diagnosed as a classical TN and treated at Toronto Western Hospital, and then subsequently followed up for 5 years. We analyzed the pre-surgical data for these subjects, and based on it, tried to forecast the future outcome of the surgery, so for how long the surgery was effective. This work essentially had two branches. We used the clinical data branch in here. We analyzed 25 clinical features using principal component analysis as a dimensionality reduction and transformation method, feature selection, and Spearman correlation against the categories of the surgical outcome duration. And on top of that, we also combined pre-surgical imaging data with the multi-class classifier model to predict the duration of the surgical response using pre-surgical data. So I'll start from clinical data. In fact, this analysis shown that pain and non-pain related measures can be used to forecast the surgical outcome. This analysis reveals strong correlation of combined and transformed pre-surgical clinical data with the surgical response duration, with the strong and significant correlation measures. So in fact, when we looked at the important measures of this component, it included medication relief degree, as well as the frequency of attacks, and presence of conditions like the diabetes type 2 and history of cancer as informative for predicting the outcome for these patients. Then we looked at the imaging data analysis using the machine learning classifier. And this model, in fact, was able to accurately predict different categories of the surgical outcome, especially the ones for non-responders and the people who will be completely pain-free, like long-term responders. So on average, model also performed very well, achieving 78% of accuracy, which is significantly higher than the random chance prediction for this type of model. Because it's a multi-class classifier, it's 25%, and we definitely outperformed that. So the important predictors for this model included 59 metrics from 53 brain regions. Key observation here is that each category of estimator had a unique set of predictors and feature weights, which allow model to distinguish this specific group from the rest of the population. So this essentially proved that, in fact, this trigeminal neuralgia disease categories are distinguishable based on both clinical and imaging data. And these findings also point some clinical and imaging-based prognosticators of specific surgical outcome in trigeminal neuralgia. And the novelty aspect of this work is the fact that using retrospective data, we're linking this disease stratification to the surgical outcome, very relevant prognostic measure for these patients. So in the first study of this work, we focused on a condition called multiple sclerosis. It's a severe progressive neurological disorder that in fact has a high comorbidity with chronic pain and trigeminal neuralgia specifically. But despite this, chronic pain is usually not in the spotlight of clinical assessment of MS. And that on its own already emphasizes the fact that the research in pain is very important for the MS population. So this work aimed to identify neuroimaging signatures of trigeminal neuralgia pain in MS. To do that, we looked at the neuroimaging from MSTN patients and pain-free MS patients who were matched by age, sex, and the duration of the MS. On top of that, we also ensured that there was no difference in the proportion of different MS types between these two groups. So the key difference was that one group is experiencing pain and the other doesn't. We compared these two groups using a combination of supervised and unsupervised machine learning methods. Just a little bit more about that. So we started from, again, unsupervised learning as an easy way to visualize our data structure. We specifically visualize parameters like diagnoses, sex, and the model of the scanner where the image was acquired on B and C, and the duration of MS and age on D and E. And based on this visualization, we could see that in these factors, data was not clearly clustered out based on these parameters, which likely suggests that subsequent machine learning driven analysis likely won't be driven by the bias towards these covariates, which essentially allowed us to proceed with the classification modeling, which in fact performed very well. Our classifier, which was trained to predict the presence of trigeminal pain in MS, achieved a very high testing accuracy of 93.4% on the testing subsets. And this model identified 17 predictors from 5 brain networks: default mode, somatomotor, visual, salience, and control networks, as important for predicting pain in the MS. So we took a closer look at these 17 structures. We compared them statistically between MS, MSTN group, and we also used the healthy control group, age and sex matched, as a baseline to see what is the directionality of these brain changes. 11 features that are displayed on the slide, as you can see, shown some statistical difference. This, for example, includes the sensory cortex, as well as the thalamus and hippocampus, regions we know are important for the pain perception. Overall observations in here are also very interesting because many of those predictors, 13 out of 17, in fact, were previously found in our first study that compared classical TN and healthy controls, which suggests that perhaps the mechanism of the pain development in these conditions are fairly similar, and the brain structural changes play an important role in the pathogenesis of chronic pain. So this is one of the first studies, as we know, that looked into imaging signatures of chronic pain in multiple sclerosis patients using machine learning. And another value of this work is that we analyzed the gray matter structures in the white matter disorder, which haven't been done before. So just to summarize what we quickly went through, in the first study, we confirmed that the brain imaging as a sole modality can be sufficient to delineate chronic facial pain. And then we identified pre-surgical clinical and imaging features that can help to forecast the surgical outcome with a very high accuracy for trigeminal neuralgia patients. And finally, we highlighted the gray matter signatures of MSTN, showing the interplay between trigeminal pain and MS, central nervous system disorder. And on top of that, this work also confirmed that many of signatures of pain that we previously found are in fact very generalizable and extend beyond classical TN as a neurological condition. So what can we really take from these studies? The first take-home message, I guess, is we now can consider having new methods to assess pain, because this work brings us one step closer to solve this puzzle of trigeminal neuralgia and effectively assess pain. So as you saw in the beginning of my presentation, the brain of someone with trigeminal neuralgia is not visibly different from healthy brain, but machine learning methods, in fact, can capture the subtle changes in the brain, providing us with a tool to identify these signatures. And our work guides us towards more accurate and objective pain assessment. The second message is more practical, but also relevant for research communities. We identified signatures that, in fact, not only help detecting the presence of chronic pain, trigeminal pain in this sense, but also can be used to forecast the surgical outcome. On top of clinical insights I mentioned, this includes changes in the brain structures within certain regions. They're currently displayed on the slide. And we are currently approaching the time when we can have and get more insights from the brain structures before proceeding with the medical treatment for these patients. And this observation on its own opens the door to a broader discussion on the potential for early diagnosis of these conditions, more effective and timely surgical interventions, and possibly even being able to cure trigeminal neuralgia. The role of surgery in this context becomes very important, and it offers a way of altering this disease trajectory. At the moment, of course, we have two possible scenarios, and we can see this full picture only on the retrospective data. But this hopefully will be the first step to shift the focus from just managing the symptoms of pain towards curing it, and essentially allowing us to choose the optimistic scenario of the patient journey for this chronic pain condition. So at the end, I'd like to acknowledge agencies that funded my research, including T-CAIREM. And I'd like to thank these great people who I had a chance to work with during my 5-year scientific journey here at the University of Toronto. Thank you very much for your attention. I'm happy to answer your questions if you have one.
Thank you so much, Dr. Latypov, for that amazing talk. We have some comments also thanking you for the great talk, and I'll welcome everybody again if you have any questions to put them in the chat and I can relay them. I guess just a question to start us off that I had. So you mentioned right at the beginning that this was made possible with a huge cohort from Toronto Western and a lot of neuroimaging data. I'm just thinking about when you think of future steps for your work and moving forward, when we're thinking about external validations and other hospitals, I'm wondering if you anticipate any specific challenges moving between different types of data that may have been collected at different sites, or any specific opportunities for external validation.
That's a fantastic question, actually. And there are so many different dimensions I can think of that might be both challenges and opportunities in that sense. First is obviously REBs, because many researchers and clinicians can relate to that challenge. If we want to collect the data from multiple centers, multiple sites, obviously we need to obtain the REB approval. And in the field of AI, that's especially relevant because right now the guidelines for the ethics and the way data can be used are currently kind of being established. And some of our work essentially sets a foundation for that. Important aspect, obviously, is the validation and how this work can be generalized. In that sense, I think we're very lucky to be in Toronto, which has a very diverse community of people. And also, in general, Toronto Western Hospital has a very diverse referral base, which includes many different ethnicities, confessions, that we can also include as a covariance to our analysis to fully uncover that. And in the future, though, I expect that potentially the need to collect the big publicly available data would be becoming more and more prominent. And we already see many examples of those happening, for example, in the UK with the UK Biobank data sets, and in the Denmark, where the public repository is available. And I really hope that we're going to move towards that direction so we can gather more insightful information about these conditions, specifically about pain in this context, but also that can be about anything.
Great, thank you so much. I also have a question here from Armand, one of our education affiliates at T-CAIREM.
Mhm.
He said, congratulations on amazing body of work. Since your work recapitulates the notion of chronic pain syndromes involving disordered brain networks, did you see any signal to suggest it is harder to classify patients with shorter duration of symptoms, so less time for pathological network development?
That's an interesting question. So one of the first ideas, obviously, then we started investigating trigeminal neuralgia, was to see, okay, is duration of pain as a disorder really matters? In fact, we found that it doesn't really differ across the patients. One interesting thing we found was that what matters most is the time of onset, which means the younger patients developing this pain, that typically results in the worse prognosis for them and potentially more severe symptoms, because as we know, trigeminal neuralgia is mostly disorder that affects people who are older adults, 50 plus. And if we see something happening in younger population, that is very unusual. And that is also associated with the worst symptoms and potentially the worst surgical outcomes.
Great, thank you so much. One other question that we have from Samantha is, do you anticipate these signatures will generalize to different types of chronic pain other than trigeminal neuralgia?
That's a very important question, actually. I think many of them, in fact, will be generalized. So trigeminal neuralgia, in that sense, by our team, is used as the model condition in many ways, because obviously it's one of the most severe pain disorders. But also at the same time, we foresee that many pain disorders share common elements with trigeminal neuralgia, because essentially most of the signals are converging in the brain, and we specifically look at the brain signatures of these chronic pain conditions. So I expect that many of those changes would be applicable to the other pain syndromes as well, and we can see that already in between the classical TN and MSTN cohort, where many of the predictors, in fact, are very similar across the board.
Thank you so much. And we just have one last question from Shooting here. She said, thank you so much, Dr. Latypov, for the amazing presentation. I'm curious about the number of samples of CTN patients and that it is much greater compared to TPN and healthy controls. Do you think this imbalance may lead the model to be more likely to predict the CTN category while ignoring TNP and healthy control categories? For example, if the testing set has more CTN samples, the overall classification accuracy might appear higher, but could be misleading. Thank you so much.
That's a good question. So it's true that we have some imbalance in here. It's also important to acknowledge that this is not the only factor that leads to this slight, for example, worse results when it comes to the trigeminal neuropathic pain group, because remember, it's still the condition which is not having the same diagnosis. These are different pain syndromes which have one common feature altogether. In terms of the imbalance, we try to mitigate this by performing the downsampling of the data, essentially, like oversampling, to make sure that the testing subsets and the subsets of the data are fairly balanced. So the model see fairly equal amount of the data, and essentially it can scale essentially the prediction based on how many samples the model is seeing. I would say the results are here likely because in general, these pain conditions are appearing very similar. And overall, if we look at the big picture in here, probably it's not very easy to distinguish it. I believe that this can be rather formulated in a little bit different task where we specifically stratify those subtypes of trigeminal neuralgia, again, based on either the clinical type or how long they had this pain for, or as we did in the second study, specifically trying to link it with the duration of the outcome as some sort of the way to approximate how severe and treatable or untreatable this condition is.
Amazing. Thank you so much. So I'd like to thank you again for your wonderful talk and also just begin wrapping up our session. So thank you so much for all of our attendees. Before everyone logs off, I just want to remind you of some of the many things that we have going on at T-CAIREM. So the first thing is that this is the second of 5 trainee round sessions that we're holding this summer. So we really hope that everybody here today is able to attend all of our other sessions, details of which can be found on the T-CAIREM website. And the second thing is that T-CAIREM is holding its first symposium devoted to multimodal data, which takes place on June 17th and will be live streamed. So everybody can attend virtually and registration is free. And we really hope to see you there. The details for the symposium can be found on our website at tcairem.utoronto.ca. And with that, I would like to wrap up our trainee rounds for today. So again, thank you to everybody for joining us. And thank you so much to our 2 wonderful speakers.